Hello, everyone. It's a privilege to present my paper of case series of 15 type 4 femoral head fractures in the 22nd APOA Congress. My name is Nitish Bansal. I'm assistant professor in the Department of Orthopedics in Government Medical College, Patiala, Punjab, India. Ours was a level 4 study. No funding was received and there's no conflict of interest to declare. The king type 4 fractures include posterior wall stapulum fracture along with femoral head fracture, which is dislocated. The optimal approach to treat such injuries is controversial and the reported outcomes are variable. We present our series of 6 patients. It was a retrospective case series from August 2018 to December 2020. It included adult patients with Pipkin type 4 fractures. We excluded patients with less than 6 months follow-up, pathological fracture, and open injuries. All patients received primary emergency care, an X-ray, AP of pelvis with both hips was done post that, and reduction was attempted under sedation using Alice maneuver. Post the reduction or the attempt, the NCCP of both hips was done preoperatively. Open reduction and internal fixation was done by a single surgeon the next day. Patient was put in a lateral position and Cocker-Langenbach approach was used to fix the posterior acetabular wall fractures by using lag screws as spring plate and buttress plate. Gans osteotomy was performed subsequently, followed by safe surgical dislocation. The femoral head was fixed with 3.5 Herbert screws or cannulated cancellous screws. Post-operatively, no traction was given, and the patient received indomethacin for 3 weeks and rivaroxaban for DVT prophylaxis for 6 weeks. Patient was ambulated the next day, non-weight bearing, and kept so for next 6 weeks. For subsequent 6 weeks, was allowed to bear partial weight, and post 12 weeks, patient was full weight bearing. Patient was evaluated clinically as well as radiologically. All patients were male with a mean age of 35.8 years. All were sufferers of road traffic accidents with a mean time from injury to presentation 9 days and to open reduction into fixation 11 days. One patient had a concomitant patella fractures. 4 had concomitant knee ligament injuries, and 1 patient had blunt trauma abdomen, a splenic injury. Reduction was achieved in 5 patients except for 1 who presented at day 17. The mean operative time was 143 minutes, and the follow-up period ranged from 6 to 28 with a mean period of 16 months. RSF score mean value at final follow-up was 71, ranging from 59 to 88, and the modified postural Merrill Day Obing score was 10.5, ranging from 7 to 15. Radiologically, 4 patients developed osteoarthritis and 1 patient developed Bruker stage 1 heterotrophic ossificans at the final follow-up. These are the pre-operative radiographs and the CT scan of one of the patients with the Pipkin type 4 fracture. These are the post-operative radiographs, the AP and the Judet oblique views and the CT scan showing a well-reduced fracture. These are at the final follow-up of 24 months, showing arthritis developing in the hip. Nowadays, as well as Henley reported better outcomes, but Engel et al. Reported poor outcomes in 85% of the patients in their series, similar to us. Delayed presentation, the surgical complexity, all add to the poor outcome in such young trauma patients. Shortcomings in our study were small sample size, retrospective in nature, and having no comparison group. In conclusion, the outcome of this injury pattern is guarded. Poor outcome in most of our patients may be attributed to the delayed presentation. Thank you.